Welcome to everyone. Welcome and greetings to all the panelists and attendees. And I'm welcoming it on behalf of a larger community of 13th International Symposium on Biomathematics and Ecology, Education and Research. And we were discussing a few minutes ago on this abbreviation. It's a beer conference, we call it. And it is organized by Intercollegiate Biomathematics Alliance, which is a consortium of universities in Midwest US and US as abroad. As part of the pre-conference event of the Beer Symposium, this is the panel discussion, virtual panel discussion on title Third Wave of COVID Pandemic Vaccine Hopes and Testing Progress, Models and Data Projections. COVID-19 has affected our society in multiple dimensions for last few months. While there is finding a cure to COVID disease is of paramount importance, an equal load of responsibility lies on the ways to quantify its burdens in presence of delay in obtaining data, in designing interventions to prevent it. So this panel discussion is actually will probably discuss on different interdisciplinary approaches in how we are combating from the mathematical models, data analysis tools, and how it is helping it in designing of interventions, testing policies, and potential vaccine strategies. And we hope to get vaccines in near future in a month or so. Let's go to the next slide. I am Anuj Mumbai, currently an associate director at Precision HUR and also faculty at Illinois State University and Arizona State University. It gave me great pleasure to co-host this exciting and informative event. With that, I would first like to introduce yourself to the organizing committee members. Dr. Edwin Michael, he's a professor at College of Public Health, University of South Florida. He was at Global Health Institute in University of Notre Dame before he moved this summer on it. He's leading a dashboard for COVID. It is called SER Cast. And he's working with some pharmaceutical industries to address issues related to COVID interventions. So this is a brief background of Edwin Michael. I will let Sudeepa to introduce herself. Sudeepa.
This is Dr. Sudeepa Chauhan. I'm an assistant professor in Department of Mathematics, Amity Institute of Applied Science, Amity University, Noida. Yeah.
Jayaprakash.
Yeah, myself, Dr. Jayaprakash Tripathi. I am assistant professor at the Department of Mathematics at Central University, Rajasthan, Ajmer, India.
Thank you, Sudeepa and Jayaprakash. Okay, well, it's when we organize an event like these ones, there is a lot of additional help that is needed. And this is an advising committee, which is also basically they are directly involved with organizing this pre-conference panel discussion as well. But they are also helping with the organization of the BEER conference. So I will let so Dr. Ojay Ekman, he's not there, but he will probably join us late in the discussion. He's a director of Center for Collaborative Studies in Mathematical Biology. He's also editor-in-chief of Letters in Biomathematics and Spora journals. And he's a professor at Illinois State University. So with that, I will ask Aditi to introduce herself.
Hey, this is Aditi here. I am from University of Wisconsin-Whitewater, and my research interest lies in biomathematics.
Padu?
Hi, my name is Padu Sesher. I'm faculty at George Mason University, and I work in the broad area of computational modeling and scientific computing.
Thank you, Padu. Sarah?
Hi, I'm Sarah Leisman, and I'm from Illinois State University, and I work with the IBA.
Thank you, Sarah. Rebecca?
Hi, my name is Rebecca Perlin, and I work at Arizona State University.
Thank you all. So with that, I will hand over to Sudeepa, who will talk about some background information about our panel discussion as well as other things related to it. So Sudeepa, to you.
Yeah. So basically, we are starting with the purpose of this particular webinar. So I would first of all take a moment to thank all of you for joining us from across the world during this COVID-19 times, when the cases are really rising up. Today's extraordinary circumstances present basically a challenge in the literal sense of the word for scientists, researchers, epidemiologists, healthcare takers, economists to chalk out appropriate policies and explore preventive measures like vaccines, cost-effective detecting kits, monetary policies which can work efficiently to combat the spread of COVID-19. The main purpose of this workshop is to discuss the role of different kind of interventions, maybe the social distancing, wearing masks, quarantine, etc., when the third wave of COVID-19 has started. Moreover, by exploring how meta-population models and heterogeneous surveillance data can be used to accurately capture the difference in dynamics of COVID between states and how model estimates and projections can be helpful in designing policies curated to suit diverse geographical regions, we can effectively deal with the ongoing crisis. More importantly, with the onset of winters, differentiating between seasonal flu and COVID poses an altogether different challenge in the testing arena. So as the length and breadth of the infection continues to claim new boundaries every hour, we need to stretch our approach for bringing in enhancement alternatives and cost-effective solutions with global public health responses. Hence, we will try to gain valuable insight from leading experts who have been there, done that, who have meticulously developed mathematical models and analyzed COVID-19 data from global perspective and not just their own respective domains. We have three distinguished panelists from versatile fields based on the type of research they do and exposure they have had, like epidemiology, health sciences, biostatistics, and modeling of infectious diseases. So to start with the introduction of our distinguished panelists, we have Professor Giridhar R. Babu. He is a professor and health life course epidemiology at the Public Health Foundation of India. Professor Babu has worked with World Health Organization for nearly 6 years, during which his efforts include stopping polio transmission in the state of Karnataka and initiation of measles surveillance. The next panelist is Professor Bhramar Mukherjee. She is a John D. Kaplis Collegiate Professor of Biostatistics, Professor of Global Public Health School, University of Michigan, Research Professor in the Michigan Institute of Data Science, and also the Associate Director for Quantitative Data Sciences, University of Michigan Rogel Cancer Center. And the third panelist is Professor Gautam Menon. He is a professor of physics and biology at the Ashoka University. Prior to joining Ashoka, he was a professor with the theoretical physics and computational biology groups at the Institute of Mathematical Sciences, Chennai. He is also currently an adjunct professor in the Department of Biological Sciences at the Tata Institute of Fundamental Research, Mumbai, India. I welcome you all, and we are really looking forward to listening to you all. So coming to just the today's activities brief. So we will start with around 10 minutes presentation from each of our distinguished panelists, followed by a panel discussion of around 40 to 45 minutes. We will have a few questions from our expert panelists, and additional questions from the audience may also be taken if time permits. So I'll request all the attendees to kindly post your questions in the chat box so that we can collect and we can get it answered from our panelists. So now let me end here and hand it over to Dr. Jay Prakash Tripathi to proceed further.
Okay. Thank you, Dr. Sudeepa. So now, without any delay, let me please introduce you, our first panelist today. Professor Girdhar R. Babu is our first panelist. He has worked with WHO as a consultant and contributed to the reproduktion of disease for surveillance in India. Professor Babu has served on several committees of the state, YMO-HFW, and Nursing Council of India also. He serves on the editorial board of BMC Public Health and other international journals. He is also a visiting professor at Maastricht University, Netherlands. Professor Babu's expertise involves several fields like health nutrition, mental health, non-communicable diseases and injuries, environmental health, climate change, immunization, primary health care, health promotion, implementation research, clinical trials, impact evaluation, systematic reviews, and health system. Now I cordially invite to Professor Babu for a presentation about his recent work and some interesting facts related to COVID-19. So over to you, Professor Babu.
Thank you, Dr. Tripathi. Good evening, everyone. Let me just share my slides. I hope you can see the slides.
Yeah. Yes.
Okay. Let me just show the screen.
Okay. Yes.
Good evening, good morning, depending on which part of the world the audience are from. I bring in perspective from working at different levels of the state government and at a corporation, city corporation level and at the national level. In addition, we have had some discussion with the public and the media and also some of the publications that we have done so far. But to put things in context, the first thing we need to be aware is where do we stand in terms of pandemic preparedness. As you can see from this graph, in terms of the map of all the different countries, whatever you see in yellow seems to be most prepared to fight a pandemic, although the reality might be different depending on how the leadership is there. The next set of countries which are in orangish color are not as good as the yellow ones, but they have a moderate score of global health security index. And the maroonish ones are definitely not that well prepared at all. But compared to that, if you juxtapose the kind of pandemic preparedness these countries have with what's the actual situation in the world now, you would see that the cases are surging in the United States. Brazil and Mexico have been worst hit, but Brazil is even bad. India is there, but the deaths are, daily number of deaths are coming down, and also daily number of cases. We'll come to that why so. So if you examine again the countries with higher burden, it appears that the daily cases and also the daily deaths are probably dropping in India, and also the test positivity rate is going down. So these are the tests done, and this is the total cases as of today. But more than the numbers, I want to bring your attention to this map with three different Indian maps showing three different things. So the first one is the number of tests done per million population in the country. And the darker the shade is, it means that the state is doing a higher number of tests. And it's not coincidence that the states which have higher tests per million are also the ones which have higher cases per million, which is shown in the map in the green color. So you would see that there is definitely a great correlation between the testing rates and also the cases per million for these states which are doing better tests. As soon as the states start reporting cases to a great proportion. That means that it's a function of two things. One, the syndromic surveillance part of it is working all right. You are able to pick up at least through active surveillance strategy. The second aspect is the testing is definitely better relatively compared to the other states. So therefore, the states with higher cases are also the ones which will have higher deaths per million. So the summary of these three maps is that if you test well, you're bound to get cases more, and you're also bound to report the deaths better. I think this is very important in terms of understanding the Indian scenario. So unlike my other two esteemed colleagues, I'm not going to present modeling results, but then the input for the models and how we need to make inferences from an epidemiological point of view. That's what I'm going to bring in here. So this is the age distribution and also the proportion of people who have comorbidities. And then a great proportion of the comorbidities is listed as other. This is the data from National Centers for Disease Control. Hypertension, diabetes are listed elsewhere, but then the other seems to be around 60% of the total burden. So what it underlies is, although it might be affecting people in the most productive age group, the fatalities might be higher if those who have non-communicable diseases. And since we do not have a good surveillance system for non-communicable diseases, we may not be able to estimate the exact vulnerability when it comes to severity and the morbidity. The seroprevalence estimates of different states is provided in this map. And then you would see that the infection is spreading from mostly urban dense areas to other urban areas and then to rural areas. So depending on where you do the survey, you'll get your estimate. So our own experience in Karnataka has been around 16% for the entire state when you only look at IgG. But then we also did in the general population, how many of them might have active infection, and that turned out to be around 12%, which means that we need to understand the transmission dynamics in states, not just based on IgG, which is the antibody, but also on the asymptomatics and those who might be having current burden. Without that, you will not be able to understand the threshold for population immunity. And these have very important implications for vaccine rollout. So we need to get these things in perspective. I wouldn't want to go into the details of state-wise because I want to be within my time frame in terms of what the important points are. So first we saw that it is a function of reporting and how good the surveillance system. Next, we saw that the background prevalence of NCDs is not very well maintained. Therefore, we don't know the vulnerabilities in rural areas and other urban areas. Third, we do not know a complete picture in terms of every state, especially if you see in the central belt, whichever you are seeing in the gray color, that what the transmission dynamics are there, which will limit any inference from any models that we do, any projections that we do. What we have done really well is we have been able to scale up the testing from 3,000 per day to more than 1 million per day, and that's a phenomenal success. But this is not uniform, as I showed you in the earlier maps, that the states which do well are the ones who will probably control well. And without going into the state-specific details, what has worked so far in India is that whether it is testing or the hospital in terms of taking care of the sick, it is the partnerships with the private sector and a coordination mechanism and leadership which has worked ways. So this is one of the things that modeling does not actually account, including the Global Health Security Index, which does not have any domain for leadership or coordination, which I feel is the major limitation. In terms of the diagnostics and innovations, in terms of testing and healthcare delivery, that's another aspect which we need to take care whenever we are doing any modeling. And I don't think that has been accounted so far. And these are just some kind of inferences that I draw from my own engagement in COVID-19 so far. Although the existing legal framework helps, we need to make sure that pandemic preparedness is done from now onwards by taking care of leadership at different levels and ensuring that the states with poor surveillance systems are the ones which will get strengthening now. We need to follow an evidence-based strategy, and some of the states are already doing. For example, in Karnataka state, based on the survey done, the testing strategy is changed already. So I think these are simple things, but very difficult to implement because you need to then build partnerships with the scientists and the industry and then the civil society. So that is most important as we move forward, not just for COVID-19, but for any health crisis as such. And protecting the vulnerables, both in terms of testing and also healthcare services, is what the most important aspect of it. And that's my biggest worry, because even now, as the infection is spreading from one area to another, the testing in rural areas is not that good as in urban areas. And the health system is also not great compared to the metros. So therefore, this is not over yet, and we need to be careful on how do we increase testing in these areas and take care of the vulnerables. So with that, I would like to thank you for this opportunity. Thank you.
Thank you, Professor Babu, for such a nice presentation and informative things related to the COVID-19 as well. So now I will introduce to our second panelist, Professor Bhramar Mukherjee. Professor Bhramar Mukherjee is a professor of global public health at the School of Public Health, University of Michigan. She is also a research professor at Michigan Institute of Data Science. She has served on the editorial board of some of the most premier bodies, such as Biometric, Genetic Epidemiology, to name a few. She is also elected member of International Statistical Institute in 2011. Her selected award include Gertrude Cox Award, Washington Statistical Institute in 2016. She is also fellow of American Association for Advancement of Sciences in 2018. University of Michigan Distinguished Faculty Achievement Award in 2018. Professor Mukherjee's research interest includes statistical method in epidemiology, gene-environment interaction, Bayesian modeling and inference, cancer, reproductive, cardiovascular epidemiology, and environmental health. So now over to you, Professor Mukherjee, and Professor Mukherjee will talk her recent to us. Yes, Professor Mukherjee.
Thank you so much, Jaiprakash, and thanks everyone for this invite. I'm going to start sharing my screen. So I never thought that I will have a file called Beer Webinar on my desktop. So you satisfied that desire that I wanted, I longed for. So greetings from New Delhi, and happy Diwali to everyone. I want to give a little bit of a snapshot of where things are. And this all started, and I just present this work, but this is a collective work of many people at University of Michigan, Delhi School of Economics, University of Connecticut. So this is you take on, once you want to do something quite rapidly, you need an army of data warriors. And I was very fortunate to have people contribute to this project. So we call ourselves the COVID-19 study group, and we started working on modeling the pandemic in India around March, the middle of March. So in the next 10 minutes, I'm going to give you a snapshot of the last 11 months and also try to do a future forecasting. So I want to talk a little bit about when we started, the past, where are we now, the present, and where are we headed, the future, so that we can all reflect and think about the last 11 months of our journey, of our scientific journey, our personal journey as human beings, because we are truly standing in a very unprecedented, uncharted territory for mankind and humankind. So when we started this work, it was the middle of March. It was the first day of the stay-at-home orders in Michigan. And India had only 536 cases at that time and 11 deaths. When we started the modeling, it was basically we were quarantined and we were very anxious about our parents, our loved ones in India, and we wanted to do something. And mostly for students of Indian origin, I initially started this work as a way to repurpose their anxiety and do something meaningful and contribute as public health data scientists. So we chose a very unusual format for dissemination of our first paper. So from March 16th was our first Zoom call of this group of 15 people. And then in the next 72 hours, we did not eat or drink, and we produced a 72, in the 72 hours, we produced an article, a 30-page article, and also a smaller version of that in Medium. And Medium, I had never written an article in Medium. And, you know, the classic academic point of view, you submit a paper, you wait for 6 months. By the time the problem is not relevant, even you revise the paper and it enriches your CV. We were definitely not standing at that point. So this work has taught me a lot about how to really not think about papers, but think about the work that you're doing and trying to provide public service as data scientists. So if you are interested in our papers and our work, this website has all our papers, all our Medium articles, and also the modeling work. Every code is publicly available for the sake of data transparency and walking the road of open science. So in that first Medium article, we compared with the world, and we said that if the world, the trajectories in US and Italy are like this, India cannot be very far behind. And we have seen the exponential growth of this virus. And this graph was widely shared in the media, where it seems like very small amount of projection at the time. We said that here we are standing in March 16th, but we can go to about point estimate of about 60,000 cases by May. And now we are having daily 60,000 cases at one point of time, 98,000 daily cases. But the upper confidence interval, this could go up to 1 million. So this, of course, the media loves numbers, and it was picked up and the news was all over the press. And we were actually quite surprised. As I mentioned, that it was much more for our altruistic project. It was not supposed to be just getting any kind of attention. And within 3 days, we had to update our models, and it taught us very quickly that these predictions are very susceptible to small changes that you see on the ground. And so within 3 days, our projections the point estimate went from 60 to 100,000, and the upper confidence interval went to 1.3 million. So at that time, on March 19th or March 20th, this article was published, and we saw the India's historic national lockdown, initially starting with 21 days and then going on in various phases, and then various phases of unlock. And it is as Dr. Babu mentioned, that there are many things on the ground that you cannot predict, you cannot capture by models. And models are, after all, deterministic equations with a stochastic layer. Human beings and civilization is bigger than that. And we saw that the lockdown had many social aspects, many unexpected aspects that were not thought about in terms of the migrant workers starting to go back to their villages, and instead of getting a static snapshot of the disease from the coastal imported cases and big metros, it was spreading to the rural areas in India. We also saw social galvanization processes when people were coming together by lighting lamps. And this reminds me, I put this one because this is Diwali, and without firecrackers, we are lighting lamps in order to get rid of the darkness that is surrounding us in this human tragedy. So, and we know what happened. The lockdown helped us to build and escalate healthcare capacity. And Dr. Babu gave a wonderful introduction and also summary of how testing has escalated, how healthcare, the private-public partnership has truly worked in India, it seems to me. And then where are we standing? And it was mentioned we are in the third wave. I think we are in the second wave. It may be the third peak for many countries, particularly United States, but it is the second wave. And this is the rest of the world. So I'll come to India, Brazil, and United States in the next next slide, what you see in Europe, all over Europe, is that there is a second surge, and we sort of anticipated that with fall and cold weather, increased mobility. This is a common season for the flu, and this first second peak is actually higher. The only thing I want to point out is that the number of daily cases is actually larger in most of these countries compared to the first peak. And several of them are again going back to modulated lockdown. This is where we are in India, Brazil, and United States. In the United States, and this data is a little bit outdated, but what we are seeing in the United States, the two peaks that you see, I consider that as a part of the first wave. What we are experiencing now is a huge surge with about 150,000 cases every day. And this is the true second wave that people were talking about, and we are heading towards a bleak winter. India, on the other hand, the curve turned corner since late September. And let us take a look at some of the numbers here. So this is data up to November 11th. And so we have 8.7 million cases, and we have about 130,000 deaths. It was mentioned that the case fatality rate in India appears to be lower. I want to point out the escalation in the number of tests, but it is a big country. So not a whole large number of population have been tested for diagnostic tests. The test positivity rate has come down. It's 4%. I was looking at the R for India. So this is a table that we daily produce at our website, covid19.org. This is the one on November 12th. And the R for the basic reproduction number at one point of time for India went down to about 0.85. And now it's creeping back a little back again, 0.98. And you see at one point of time, except Delhi and West Bengal, all of the states had the effective reproduction number below 1. And you are starting to see some activities here again. And so it could be the festival season. It could be just people are tired, fatigue, habituation, desensitization. It could be various confluence of different causes. And so every day we are pretty much having 40 to 50,000 cases, and we are having 500 deaths. So approximately. So, and this is what I was mentioning, that the test positivity rate is a good indicator, and we produce this table just to get an idea of what is it today, was it yesterday, and what was it 1 week ago. And the R curve, as I mentioned, that it went quite below 1 and again creeping back again, and you can expect that. So the question is that modeling, in terms of modeling, what I have learned is that this is a very unusual territory because a lot of the things are changing every day in the ground. And so you cannot stop modeling. You cannot have a static model. So let us just take a look at Delhi. This was Delhi in June, and people were just saying the predictions are going to be atrocious, and there are going to be lots and lots of cases and deaths. So Delhi really buckled up, people hunkered down. They increased their testing quite a lot with the rapid tests, which are not as perfect. But then the curve came down, and we could see that by August, the curve looked like that the curve has turned the corner. And then again, you take your feet off the brake, and what happens that you have another surge. And then you do again and intensified messaging, and now you're experiencing another surge in Delhi. And with air pollution, with Diwali, with all of the winter staying inside with the cold weather, I think we need to think carefully about the healthcare capacity. Yes, maybe the death rate and the fatality rates are not high, but the healthcare capacity has been a true indicator and a metric for me as a modeler to look at. So where are we headed? So this is the present, and where are we headed? And we have heard very polarized opinions from the scientific community, and many of us have been debating the Great Barrington Declaration. So about 620,000 concerned citizens have signed this declaration. About 11,000 scientists, public health scientists have signed this declaration. The main crux of this declaration is that protect the vulnerable, but open up the economy, open up the education sectors, and just say that people who are at more risk may participate in these activities if they wish, but the whole society as a whole will enjoy the protection conferred upon the vulnerable by those who have built up herd immunity. So there is a lot of controversy about this declaration. And I personally, I am not advocating this, and I do not feel this is a sensible idea, because I always think that death and cases are not a statistic. If I cannot recommend this for my daughter, and I cannot recommend it for my father, I'm not going to recommend it for the public. So, so this herd immunity, this notion of herd immunity, and what percentage of cases in India truly actually infected. So this is a modeling question where many people have dabbled with this question. So I was on Karan Thapar's show, and I quoted at that point in August that India may have 30 million cases, and then in 6 weeks it may have 100 million cases, and people were astonished by that number. But the seroprevalence studies and the other work also corroborates that there is a huge degree of underreporting in India. So the seroprevalence studies in Delhi, and one thing India has done remarkably well in these metros is actually this longitudinal serosurveys, and which we have not seen in the United States happening. So what we see in the Delhi serosurvey, that initially it was 22%, and then it was 29%, and we see that. And so what the seroprevalence is giving us, it is the ephemeral antibody response or long-term immunity. We need to think about that. So, so some of the methodological work, the most interesting methodological work as modelers, because this is a conference about biomathematics, actually came from some of these issues. And then some of these, my conversations with Mr. Thapa about how to give these accurate predictions in terms of underreporting for cases and deaths. And so we have a new tool called ACIR Fancy, which takes into account the false negative and symptom-based testing that is happening in many countries. And we estimate that there is an underreporting for cases as well as deaths. So all of these calculations, regardless of what we feel, it gives you an infection fatality rate for India, not the case fatality ratio, about 0.1 to 0.8%. Even if I assume that this is the lowest infection fatality rate possible, if we pursue herd immunity, if I let 50% of India get infected, then we'll have about 670,000 deaths. We are at 140,000 reported deaths right now, 130,000. And so are we ready for that? And we might decide that as a society, the economic costs are too much, the societal costs are too much. So this is our strategy, but we really need to base that strategy guided by data and guided by reliable modeling projection. So one thing I've been thinking a lot about mathematically is optimal testing strategy. Recently with my students, we released an app. This is the link for how do you distribute tests? What is the optimal number of tests, and how do you distribute it to the vulnerable? Based on age, based on symptom. I think these types of tools are very useful even when we come to vaccine distribution as well. So moving forward, what I think is that the public has a very serious role in public health, and community participation is going to be very necessary and key here. We definitely need this population-based periodic serosurveys, and I strongly think that there should be a national follow-up cohort of people who are being declared as recovered from COVID-19. It would also help us to track seroconversions, but also there are long-term health complications. One of my friend's father passed away after being released from the hospital after 4 weeks. And so there are obvious deaths that are happening in this period that we really need to take into account of. And then data. Data, I think, is the key at the heart of many of the public health intervention strategies that we are thinking about. How many beds, how many ICU beds, how many ventilators? As the vaccine comes out, how are we going to distribute that in a risk-informed way? So we need better data. India has been a very data deficient infrastructure, and that's hurting us because we cannot really gauge that what is the daily death and admissions data and how many excess that's happening at a various granular level to track, and the pulse of the pandemic, I think it's very, very important. So with that, I think I'm going to conclude my presentation, and then in closing remarks, I want to talk a little bit about the humanitarian side of the pandemic, and this was the modeling side. Thank you very much for your attention.
Thank you, Dr. Mukherjee. That was really an excellent talk, and you have very well explained related to the several facts related to COVID-19 incidents country-wise, different aspects related to the mathematical modeling of COVID-19, and also finally the optimal testing strategy. Thank you so much, Professor Mukherjee. So now I will introduce our third panelist of this panel discussion. Professor Menon. Professor Menon is a professor of physics and biology at Ashoka University. He is currently an adjunct professor in the Department of Biological Sciences at Tata Institute of Fundamental Research, Mumbai, India. His selected honors allocates include being named an outstanding referee by the American Physical Society in 2012, as well as recognized as an outstanding reviewer of the UK-based reports on progress in physics in 2016. His area of interest include biophysical problems, including nuclear architecture, axonal transport, collective cell migration, and cell adhesion, all in the general field of mechanobiology. The modeling of infectious diseases and its implications for public policy is a long-standing interest of Professor Menon, while the use of machine learning methods in clinical context is more recent one. So now over to Professor Menon, and he will talk about his current research interest in COVID-19 as well. Yes, Professor Menon.
Dr. Menon, you are muted.
Sorry. Let me thank the organizers for this very kind invitation to speak at this meeting, and also
thank
to be on the same panel as Bhramar and Giri, who've been virtual friends ever since the pandemic started. Let me share my screen. Okay, if you can see my screen now.
Yeah.
So this is so
we see the presenter view.
Okay, you mean you don't see the full screen view?
No, we don't see. We
no, we are seeing several slides together.
Okay, so let me just try that again. And if it doesn't work, it doesn't work. We'll just take it together. Yeah, this is, I think, I'm not sure why this is so, but if I'm just, this is what works at the moment. So I don't want to mess it up. And are you still seeing the sidebar?
Yeah.
But is this okay? Can you manage with the sidebar while I speak?
Sure, that would be okay. It's fine.
Something came in between and then
let's keep going.
I went to the next slide, so I'm glad that at least worked.
Yeah, it's fine.
Okay.
It's fine.
It's fine.
Okay, all right. So my own introduction to thinking about COVID-19 and beginning to work on it came when we formed a group called the Indian Scientists Response to COVID-19 very, very soon after the first couple of cases began to be reported in India. And we realized that this was going to be a very huge public health issue for the country. So right now, the Indian Scientists Response to COVID-19, or the ISRC, numbers somewhere between 600 and 700 members, scientists from all over the country, also from outside, people who work in science communication, etc. And as part of that, there's also a modeling group of about 10 people from multiple institutions across the country, the Institute of Mathematical Sciences in Chennai, Bangalore, Goa, Delhi, Pune, and so on. And we brought out a set of reports based on a model that we developed, in which we were trying to understand what could be useful in terms of projecting the progress of the pandemic through India, and what might be the points at which policies might be able to take in information that was generated by the model and to decide and to sort of make appropriate changes in the way policy implementation was actually carried out. So this is the web page, the ISRC web page, which you can look at, where we have a bunch of our reports. We're on the verge of releasing version 2 of this, which is far more complicated. Let me tell you a little bit about this model and what we decided. We first decided that we would start with a compartmental model, which is in a sense the simplest of possible epidemiological models. This is what the model looks like. It has 9 compartments. There's a susceptible and exposed, a pre-symptomatic and an asymptomatic compartment. The pre-symptomatic goes into either mild or severe disease states. Then of the severe, a part of them will be hospitalized and then will recover, and a part of them will die. The rates in this particular diagram are determined a combination of data from China, from Italy, from the US, as well as from India, increasingly now. So we have a little more handle upon this. And we represent, with a model like this, you can represent the effects of various types of interventions. For example, lockdowns or changes in contact through these parameters, CS, CP, etc. So these equations one can write down. And this is a compartmental model. It's actually a metapopulation model because it's a model currently for every district in the country that allows for migration between districts. It's age stratified. So every district has its own age distribution and a distribution of susceptibilities, for example, or the rates at which you're hospitalized as a function of your age. You can also put into this local district-wise access to healthcare. So some people who are symptomatic may just go directly, may avoid the hospital stage and go directly to the death stage with some probability or recover. And you can assess the rates at which these happen based on health information that we have, health data that we have for India. Here's one example of what we did with the Pune Municipal Corporation. This is their data for critical hospitalized cases. So that's the black dots that you see are actual data. And this is the band. We predicted this twice, one very early on where you thought we began to see the onset of the band, and one about, I think about a month ago, where you can see that the band that we predict, the sort of grayish band in the middle, is a range where we said that the critical active cases would actually stay within. And you can see that there's a point where it moves out of that band and then it suddenly comes back. And that was the point at which the corporation discovered that there were more cases hospitalized than needed to be, because there were many people who didn't require hospital attention. They could recover perfectly well at home. So then it came back into that band that we defined. And that's an interesting question. Was it the model that was right or the data that was right when you think about a situation like this? We do similar things for every district in Karnataka. Since I said this is a model for all districts in the country, this is again data, and our model fits to the number of cases in Chikmagaluru, the number of deaths. All of this is information that we actually derive from the model that we study. Here's an example of work that we did in Delhi, where we looked at the progress of this. So we fit our data very well to Delhi up to about the point of July, and then we look at what happens if you relax various interventions. So you can look at the effects of relaxing on August 1st, having more people come out. And if you look at the mobility in Delhi, you can see that from the 1st of August, it's actually steadily been going up from about 10 to 15% to more than 25, 30% at the point. And we said that this would invariably lead to an increase in the number of infections, an increase in the number of hospitalizations. And we plotted out a band that showed this. And you can see in the Delhi data that you see below, it sees the peak and the trough and the peak and the trough, and then to the right, further off in time, the third peak that we seem to be seeing at the moment. There have been some discussions about how many people are actually infected in India at the moment, and particularly in the context of a so-called supermodel that the Department of Science and Technology put out, which pegged that number at about 400 million infections. And our own numbers are more conservative than that. We estimate right now, Bhramar had made a mention of this in her talk, probably around 250 million infections as of a few weeks ago, maybe about 2 weeks ago, which is certainly less than the 400 million that was from about a month ago, as far as their projections went. So still nowhere near what we might think of as being herd immunity in any context in which we've discussed that particular question. We worked on another set of models. As I said, I'm a modeler, so I work on multiple different types of models. I'm not particularly deeply committed to any particular model. And this is a model that is a slightly simplified version of the earlier model. This also has mildly infected and severely infected, but it doesn't have a death category because that wasn't the problem that we were interested in. And we look at this in the context of networks. So the network model that we're thinking of is one in which people are at home, or they're at work, or they could be at hospital if they require hospitalization. And you have healthcare workers as well. And you have networks that describe the nature of interaction between people at home, people at work, a distribution of workplace sizes, the distribution of sizes of homes, average number of people at homes within a certain model community. And the networks that we use are sort of kind of super spreading networks. They're not extreme super spreading networks, but they're somewhere in between. The questions that we wanted to address here are like the questions that Bhramar mentioned. The question, what is an optimal testing strategy for a situation like this? Remember that the problem in India is that you have a combination of RET and PCR tests. States like Tamil Nadu do a completely PCR-based testing. States like UP and Bihar have somewhere between 40 and 80% of RETs. Now, you know that the on-field performance of the RET tests that are being used in North India are probably somewhere between 50 and 70%. And a similar number, I think, for the more symptomatic cases is also true in the Karnataka data as well. But there are different versions. The ST Biosciences have brought out different versions of the test. Some of them have a 74.5% sensitivity. Some of them have a 93% sensitivity. So the quality of the testing is improving with time. Now the question is, if I gave you a test of a specific sensitivity, I allowed you to test at a particular percentage of the population per day. I said you are now 200 days into the epidemic or 100 days into the epidemic, and 5% of the people are already infected or 10% are already infected. What is an optimal testing strategy and what is the right mix that you should do? Here's just a quick summary of different levels of testing. And these are somewhat large numbers. Typically, India is testing at a little less than 0.1% overall in the country. If you look at different states, they're testing at somewhat larger numbers. So between 0.1 and 0.5 is probably an optimal window, which seems to be feasible within the next 2 to 3 months. How do you vary that if you change RET sensitivity versus the fraction of RETs? What is the optimal level at which you should be testing? Given that now you're not at the beginning of the pandemic, but you're somewhere way through it. So different districts can have different levels of seroprevalence. You can have a seroprevalence of about 5% or 10%, in some cases even 30 or 40%. So what again is the strategy? And this is sort of ongoing work. So I'm just going to show you this picture and saying that this is what we can calculate and finally try to arrive at some sort of policy prediction for what might be happening. The third category of work that I've been doing with my group is very, very much ongoing. And that's a very large idea of developing an agent-based model called BharatSim. And this is an ultra-large scale simulation of agents where you want to simulate somewhere between, let's say, 100 million and 1 billion agents on a computer. And these agents have properties that derive from a synthetic population. And the synthetic population summarizes as accurately as possible what you know about the statistical properties of the Indian population state-wise, even to the level of districts and sub-districts. There's a lot of information that goes into this. And in fact, the preparation of the synthetic population is really a very, very large job in itself. You want to put in everything that you know about the demographics of the country, in particular regions, with Orissa is different from Kerala, it's different from Maharashtra. All of these details you want to be able to put in. So we also use somewhat high-tech machine learning methods to make sure that the way we construct the synthetic population is really consistent with what we know. And we use survey data in order to make sure, act as a further check on the quality of the synthetic population. An ideal synthetic population would give you exactly the same results whether you did it on the computer or whether you went out and did the actual survey. So that's what we're trying to aim at. And this is work with a company called ThoughtWorks. And the synthetic population integrates multiple data sources on gender, age distributions, family sizes, the various types of health surveys that the ministry has done over multiple years, socioeconomic data, healthcare access data. And finally, the hope is to make all of this a publicly available resource for anyone who wants to be able to use it. Certainly, the variation of population in the country, you can see it's a very nice image where the peaks represent sort of increases in population. You can see Delhi is a big peak that sits somewhere right in the center. And all of this will figure into BharatSim as we think of it and describe it. This is in the future. We hope to have some prototype of BharatSim ready within about a month's time, and maybe the much more refined, larger scale in the synthetic population with the agent-based simulation, again available to the public for public use within another 3 to 4 months from that time. So that's really in the future, and I'd ask you to look out for it. As always, this is not my work. This is work done with large numbers of people from all over the country. The InsiSim group is a large group. The Pune Knowledge Cluster has also been collaborating with us. I work on networks and testing with a group in Bangalore and in Sonepat. The BharatSim is, of course, a complicated collaboration between a company, between us, and multiple collaborators all around the country. And we've been looking at the Karnataka data together with Rajesh Sundaresh of ISC and Sivatri of ISI. So that's all I had to say. Thank you for your attention. And it's very nice to be here at this wonderfully named meeting. And again, with this wonderful panel, I look forward to questions and look forward to discussing all of these issues with you.
Okay. For such a nice, interesting talk. You have talked very well about different kind of models like meta population model, agent-based model, and different type of data analysis related to these models. So thank you very much for such a. Now I thank to all the panelists of the panel discussion. And now we will move to the panel discussion, and we will start the first question of the panel discussion. And now I invite Professor Mukherjee to start the panel discussion. Professor Mukherjee.
Thank you, Jay. So I just want to restate actually, the idea behind this panel discussion was to bring interdisciplinary panelists who are pioneered in the respective areas and talk at the same podium on different aspects. And as we can see from their talk, Dr. Babu talked about how empirical informations have been gathered in the field and how what challenges that one feels, and they are not homogeneous talked about how you use that information to massage it and give the information that in a real time would be useful to you. Um, for example, seroprevalence survey and follow-up surveys to consistently draw implications which are useful to the community and to interventions, design of interventions. And finally, Dr. Menon was talking about using these mechanistic mathematical models to how we can link this empirical informations to data analysis and using those things in the estimates, those data, the average quantity of certain behavior, population behavior or epidemiological behavior into these mathematical models to draw projections from those ones. So thank you all the panelists. With that, I will quickly move on to Jack. Can you please mute your microphone? So for the first question, I will start with Dr. Mukherjee. And this question is on the science of social distancing and wearing mask. And in fact, instead of saying social distancing, it could be physical distancing. We are doing it for last number of months. And we have learned so much of information from these interventions, but still at many places, we are seeing the hike in number of cases, the surge in cases, in spite of these things. Are we not estimating? Do we these intervention? What these interventions are doing in the communities? Are we measuring those things in the fields? And if so, why are these cases rising? And the second related question is our models have not still learned enough? Or do we need, what is missing in the field? Why is the cases still going or surging basically?
Yeah, so that's a great question. So thanks to the media, we see whatever the media projects, right? So we really need hardcore ground level data. So there is a paper which came out at the end of October in Nature Medicine. For the United States, when IHME does the model, what they project is actually at the end of February, by February 2021, they expect that there will be 511,000 deaths in the United States, and just 95% adherence to mask in public places can cut that number down, given that we are already standing at 240, 250, by 130,000. And then if you have 80% wearing of mask, this is again a mathematical modeling where you put in the mask wearing behaviors, and then 80%, this number could go down by 95,000. So you can see that mask wearing will have an effect, but it's not the whole number of deaths that you are seeing. So, and I think that the masks are not the best thing that you can do, but it's porous. The system that we are having to protect against the virus are porous. Still, the virus is coming. And in the United States also, we are seeing a lot of cluster infections from small family gatherings where people feel that they are safe and take off the masks with like 6 people inside. And there was a whole cluster of cases at the end of summer from the smaller family gatherings. So I think that we are not fully protected by masks can really help us. That's quantified. And that has to be at a global level. What percentage of the population is wearing masks? And because it's not just for you, it's to protect the others as well. And what kind of mask? People have a face covering, but in India, when I go out on the market, many people do not have their nose covered. And so to what extent are we having and what kind of face coverings we are having? But also this small gathering and the cluster infections are also quite important, that not just in public, in that setting as well. And in those cases in China, centralized isolation was very useful because Indian households are also often quite congested and you don't have the room for self-isolation. So the entire family gets infected. So I think that the social distancing measures can only get us this far, and it is not going to be foolproof. So, but I think we can quantify the effect of it as the models have done. And I have not seen a model like that for India, because I don't think that there is good data on granular level of mask usage throughout the country at a level. I do not know. Maybe Gautam or Giridhar can comment on that.
Sure. Dr. Babu, Dr. Menon, you want to add something to what Dr. Mukherjee was mentioning?
I think the only study that I know of is a study from the National Institute of Epidemiology in Chennai, which I think found, my guess is about 60 to 70% mask wearing, but found that a lot of people, exactly as you said, were wearing it inappropriately. So it's not very clear that that was useful at all. Then the IHME projection has, I think, something like 70%, but it's not clear to me where they get that number from, because they're not very specific about how they accumulate the data. There's some collaboration with Imperial College, collaboration with various other people in India. So there's 70%. I don't know where that number comes from, but that certainly is a number that they estimate. And they say if you push that up exactly as you said, up to 95%, then you do have a substantial saving of lives.
Yeah.
But maybe Giri has more information.
No, I wouldn't counter with evidence, but then I was only going to address why there is a surge in cases despite people complying to different proportion of mask use. And the answer, Dr. Anuj, is that when do you do all these public health regulations? So while the lockdown was going on, people were washing hands, using masks. And when the unlock has begun, people might be really having this fatigue of, for how long will I do this? And therefore, even those who were following earlier might have given up. One. Two, earlier, the most dense areas of urban areas got infected. Now the infection is going to other areas where with relatively less population density. So therefore, there will be cases coming there. And also, I would say people are moving in installments. Initially, they were staying inside, and then the working class came out. Now with free movement, everybody is coming out. Even now, there are people who are still fearful, and then they don't come out. So as the population movement changes from time to time, they get, since everybody is susceptible, nobody has any immunity God-given. So no vaccine is also there. So it's a matter of time that people get infected. And therefore, the only question is when, and if yes, are we testing them or not?
Okay. Well, so I think the follow-up could be this,
Anuj, sorry, can you hear me?
Yes. Is it Edwin?
Yes, yeah. I'm sorry, guys. I was just able to join just now, so I missed the talks. I just wanted to say something in terms of estimating. Anuj's question: how can models estimating face, physical distancing, face mask wearing? What impact is that doing to the epidemic? And I just want to share that. The model that we are creating, for example. We use local data. I mean, we do need local data. These are case or deaths data. I mean, and, as an example, I'll give you that, we're doing it for all the counties in the US. And similarly, we can start looking at, state level data in India as well. And we do this, so we take this model and sequentially update parameters in the model. One of the parameters which is the model is addressing is the amount of face masks wearing and physical distancing. So you can parameterize it, saying that can we capture that information using the current case data. So these are Bayesian updating processes that we use. The other thing, coming back to, I think one of the participants, I think it's Bhramar, right? She was saying it's not just face masks, which are important. It's also about, the mixing, which is occurring in the population, schools reopen, et cetera, et cetera. And so in our model, we try and get estimate of people moving in a county or mixing in a county using, mobile phone data. So if India wants to go down that route, and we looked at India and we couldn't find a provider that can give us, mobile phone information showing how people are moving in a particular district, or state, etc., etc. If you get those two pieces of information, then it's possible to periodically update the parameters in the model.
So Edwin, you are asking probably whether this type of data are being collected in India or not, and maybe Dr. Babu, if you can add like what empirical information that are being used in upward, like in the models and in data analysis to draw projections from there.
Yeah, I think Gautam and Dr. Bhramar can also add, but I know that there is access to data, at least for the public sector. One of the things is the app that was used, which is authorized by the government of India and also many state governments which have done. They have immense data. For example, I know for sure that how many people report that they have illness on this app, and that will correlate really well with the kind of testing done and how the cases per million detection done in the district. And the cell phone data is used really well, at least in Karnataka state, both for quarantining purpose and also to ensure that people do not leave home, although there are concerns regarding privacy and how much the law can use all this. But then I think India has done well in use, at least where the technology or the people with technology have been working with the government, but it's not uniform everywhere. Gautam, if you want to add anything.
No, it's the same points. I think Google Mobility Trends is one source of some information that we have for how mobility has changed. Arogya Setu, which is a government mandated app, which suffers a little bit from the fact that the uptake is not universal. And there's been partly because courts and government have been on slightly different sides in issues of privacy. Can you make it mandatory at all, or should you not? And that has sort of tended to vary a little bit. But that data is being used. I don't know of any model yet which sort of combines both the epidemiological part, derives betas and contacts from that data as yet. But I suspect that some of this data is already there, but it may not be in perfect form.
I mean, we did look at India data, right? And if you look at their state level data on cases, and this is on the KGO, whatever site, and we can access that data from the beginning of the pandemic in every state. So that data exists. But what we do lack is data on people's movement, within the state. And that in the US, companies like Unicast are providing that data at the county level and also between county migration, movement for people who are going to work and things. And those are very useful for our model, as one of the, inputs into the model. So, is there a provider in India like Unicast, which is providing those kinds of, mobile phone signals?
So, yeah, so I just want to add that, our Bayesian updated models are for all Indian states, and we decided to use just the case counts and the death counts and stay with a simpler model, which is uniform across all states, because we could not get homogeneous level of data on mobility as well as age-specific contact network. So I think in order to put every model on the same platform for each state, that was the case count time series was the only thing which we had uniformly for all the state specific model. I think it's a very important message that India is a very heterogeneous system. To model it as a nation is probably not a great idea, because to predict the peak for India, when you really have a cascade of peaks or a series of hillocks and knolls, and so you really it's a conglomeration of what's happening at the state level. So I completely agree that you really need to build the model up and not top down.
Yeah. I mean, for example, over here, we provide simulations at the county level, and there's a great deal of heterogeneity. So when you begin to bring in strategies to curb the pandemic, and also when the vaccines come, where do we push the vaccines first? In a state, I mean, Indian states are huge. Yeah. So which district, do we need to push the vaccines first, for example? And that also depends on movement between districts. So but the models are there. We have the models, provided we get this movement data, and or we estimate it by, as Bhramar was saying, it's a less efficient method, but we can estimate from cases as well. But we need local cases, district level cases.
So maybe I can address that very briefly. So
yes,
that
sure.
we do have migration within our models, within the model that I described. You can do district level migration. Right now, all those terms are switched off because of the relatively low levels of migration between this. You can put in migration using gravity models. Sure. Ideally, we would like the sort of data that you're talking about, but we have not been able to access it yet.
But we can start with gravity model. I mean, I agree. We can start with gravity model.
So that's what we have. Yeah.
So I just want to, so I think we are talking right now about getting and right type of data, or what type of data can be used in these models for projection. There is a related question to that, and that I would address it to Dr. Gautam actually. And you build a model, you draw conclusions, and there have been some models, at least in India or elsewhere. Are the policymakers using that implications from these models in a practical fields? Are they using it in their interventions designing, or we are just doing as an exercise for that matter? So.
That's a hard question to answer, and I think the answer is it's a sort of very staccato relationship between government and modelers. There are presumably modelers within the ICMR who provide some sort of modeling framework to government, but there's not much interaction as far as I know, apart from isolated examples. There is certainly a modeling group in Bangalore which supplies sort of modeling and statistical information to the Karnataka government. We work with some governments, and I don't want to tell you which ones, but certainly some cities in different areas to tell them, but all of this is on a slightly informal level. And that's really a big lacuna. The fact that there is no uniform method by which scientists outside the government framework can interact and provide examples with, and ideally what you would need is some sort of ensemble model. A bunch of people doing different things, for example, Bhramar or other people like us, making projections, and then you have some ensemble way of combining them so that government gets an idea of how to go forward. This is not there, and this is a serious issue. That really would be the right way to actually do this. Unfortunately, government has not taken this up.
I mean, I can, in the US, we provide simulations to, for example, to the governor's office here in Florida, and so they do want to know, what is the cause of the epidemic, over the next month or so that they can start planning at the hospital level, right? Capacity and things. And we also provide, for example, at a local level to over here, I'm in Tampa, so there are 4 counties that make up Tampa. And so they have a surge planning committee that meets every 2 weeks, and we provide the simulations, and they actually use that to think, oh my God, what's going to happen, a month from now, 2 weeks from now. But I just want to ask, and so my interactions with them, the problem is, risk communication. We are very poor in actually making them understand what the risk is. And the second thing, this model, our model is an ensemble model, Gautam. And so we do, 2 or 3 types of updating. We use 1 week block data, or we use 10 days block, or 2 weeks block. And then we build an ensemble because they all give very different answers, So we need to also teach, the policymakers saying, for example, if I give a 1 week update, that shows that's the most recent data. And the most recent data is showing spikes. And so when you forecast to the future using the most recent data, you're going to get a huge surge, right? Because it's really fast uptake, exponentially it's driving. When you use a 2 week block of data for updating, that is much slower, rate of increase. So that will give a lower, cases. So we tell them, look, this is the worst case scenario, this is the best case scenario. And somewhere in between is where you're going to lie. And so we need to also teach policymakers how to understand, this kind of variability, credible intervals. They can't and its credible intervals are huge. A month from now, 2 weeks from now, they're much tight. So, but they tell me 2 weeks from now is of no importance for them because they can't plan. The lead time is too short. So they do want like a month from now. But the trade-off is a month from now, your confidence intervals are much bigger. So those are the trade-offs I think we need to also communicate with politicians and policymakers.
Let me ask Dr. Mukherjee also related to the same part that we are discussing. You have been here in US and you have also working with Indian collaborations. What do you think, like, what is the difference in the modeling implications from what we have learned from models versus how the policy get implemented? How much is the difference, whether there is similarities in that regard from India and US, or there's a huge difference in that, and what are we missing?
First of all, I think that I would like to comment on the modeling question, whether the policymakers are using the models or not. I think that there is one favorite model that each government works with, and there is a lot of other models which are in the community. And so the models are also going as exponentially as the virus. So that's a problem. So I think that you have to think about it. And so you think about the supermodel, for example, that the government endorsed as the projection model that they are looking at, and there are some issues with it. So the more people give input, but I'm less concerned about whether the government is using my model or not, or somebody else's model, as long as there is a sensible model and there is a data-driven strategy and people are looking at it. But also I would say that through social media, you have enormous power as scientists to have your voice heard. And so I do think that when and with Twitter, with your scientific communications, with the journalists and the media, and I distinctly recall that through a group of journalists, when the second wave was coming, and I was very frustrated that nobody is maintaining this, and there is no listener, you need the public health cooperation in order to do anything about the pandemic. I wrote several articles and talked with several journalists, and when it appears, you know, in New York Times, in Washington Post, and then there is an attention and a pressure. So I do think that there is intensifying the government's message. So I do think scientists have an alternative way of also communicating. So we should not really undermine that power that we have these days in terms of our models. And also, I personally feel that a lot of people go to the websites and the dashboards, public, who are getting informed by the data. That's also a very tangible contribution of all of these models, because it is very hard to, you know, misinformation and disinformation has its own circle and orbit of spread. But if scientists from good institutions are actually putting the work out there, and without thinking about publications and grants, this is just to help the public, because we are in a big public health crisis and we have responsibility towards the public. So I think there are these alternative forms of dissemination that I personally have been very enriched by. And then the other thing is that why the models are, I think you have to proceed the models with humility, because what the human beings do on the ground, that can change the course of the model. Our model predicted a peak for India, the first peak, in January, and it happened in late September. So we were grossly wrong. And I think that's where the humility part of the model comes in, that the long-term forecasting of all of these models are actually I'm quite skeptical about that. Short term, I think it's great. And also models can be used not just to now track the number of cases. We already know that there will be cases, as Giridhar mentioned, but how to deploy healthcare resources, how to think about vaccine, risk stratification, where to target at a geocoded level, these alternative sources. So I think that we have to expand our repertoire and use of models.
Well, I would continue this conversation. It's very interesting with Dr. Babu, actually, because he's on the other side of the modelers, and he's actually part of the, I think, Karnataka government health department. And so from administration and health decision-making perspective, how the health ministers and how the health departments are taking these modeling implications and using it, these results from the models, if you can comment some points on it.
Yeah, so I must say that I am fortunate that I'm in a state where they look forward for these differing opinions from scientists and technical groups, and it does not matter whether you take their side or not. because they do not have any sight, because nobody knows anything about this pandemic. So in the beginning, they were asking questions such as how many cases will be there in Karnataka state and how the state has to prepare. Then when the surge started, they wanted to know when the surge will occur and where it will occur. Now they're looking at how it is spreading and then how to plan in other districts. At each stage, there were several modelers, even though I did not do modeling per se, but I have reached out to several people and many people have contributed to the state of, and this is the best thing about this collaborative effort, that people do come forward, they give these inputs, and the state has freedom to choose. And as Dr. Mukherjee clearly explained, whether the government picks up a particular model or not, it's not important, but then as long as there are inputs, there is discourse going on and there is a discussion going on where people eventually will have to listen to the truth. So currently I'm looking at how do you prepare then for vaccine? And this also has to be in terms of evidence-based. What is the seroprevalence there? What is the actual burden there? Who are the risk groups who are getting affected? And therefore, Karnataka has got benefited because they are a very receptive state. Few states may not have done it because they have chosen a different path in the beginning. But eventually, I think at the national level, this data sharing using evidence for policy has to become a culture. And that's a long way to go.
Dr. Menon and Dr. Mukherjee, you want to add something?
I just want to add that in the United States, I think that I was not directly involved, but the government, in the state government, the Michigan government really worked very closely with all my colleagues in epidemiology, and even our faculty and students were at the governor's press conference talking about the models, which is predicting the surge in Michigan and defending the lockdown strategies, because it became so political, as you know, particularly in Michigan. There was a lot of protests, lots of social chaos. And so we needed data to say that if we do not do lockdown, if we do not have these restrictions, then this many lives will be lost. And so the government was really based on, our governor, Gretchen Whitmer, was a strong supporter of science and also these projection models and she used the modeling tools that our colleagues developed. So it was very highly integrated. I cannot say that about the whole national scene.
Sure.
Well, I just want to say one thing. Sorry, guys. In many states, what was really interesting is, when we connect, in Florida, we have the hurricanes, right? And they all use the weather models. So, people in this state, they are already used to this kind of large scale models, in order to plan their daily lives, when the hurricane forecasts are already embedded in their daily lives. And so when we talk to policymakers, we also highlight that this is the same kind of principle. These are data-driven models. Just like weather models, we take data, recalibrate the models, and then make forecasts. That doesn't mean the forecast is going to, there's a probability, attached to the forecast, what might occur. And then they can see the connection, that the models are giving you some probabilities, in terms of what might occur, and it's not exactly precise, but this has got a high probability that this will occur, a lower probability that something else will occur. And that is one thing that I found, that the policymakers over here in Florida were immediately connected, because they're so used to dealing with weather phenomena, in their lives, and they always use those data-driven forecasting system.
Okay, so
I just wanted to I just wanted to very briefly comment that I agree with Bhramar that it doesn't matter what model is used. It matters that they're evidence-driven and data-driven, and that is I think the really important point. The second point I wanted to make is, even if you look at the US projections, for example, that the Wright Group at UMass Amherst produces, they're right now all over the place. And so, you know, one should not be embarrassed about having models not work. There will invariably be models that work. Some of them will work well, some of them will work badly. It depends very much on contingency, on the sort of approximation. And the one lesson that we've learned for India, at least, which is a generic lesson, I think all of you will know, is that you should not predict for the country as a whole. You should predict as micro level as possible and make up the whole country behavior, because I think, I forget who it was, maybe it was JP Mulial who pointed out that this is actually 100 epidemics at the same time in 100 different places. And it's the sum of this that we're seeing at India. We should really be concerned about each of these micro level things and figure out models for each of them.
Yeah. Well, in the interest of time, thank you for all these comments. I wish we could continue this conversation for another 1-2 hours. You know, the more we discuss, the more points comes into our minds. But in the interest of time, I would like each one of you, if you can give some concluding remarks on your views of how we will handle coming December. There are issues with the flu. There's issue with the flu and COVID together. There's issues with the vaccine. If you can draw some conclusion, maybe in any order will be fine. So whosoever wants to go first.
I'm up first.
All right. So I prepared closing remarks because I think it's important for me to share these slides. So I want to depart a little bit. I want to go from my personal story to go to the humanitarian component as my concluding remark. So I took this figure from the 1918 influenza pandemic for India and what happened. And prior to this pandemic, I was not an infectious disease modeler, but I have really been struck by the predictability of what happens with the pandemic. And this was, many of you know, this was called Bombay fever, and it was really, really bad for India. About 5% of India's population died according to different historic estimates. And you see Bombay, and at that time it was still the British names, and had the first highest peak, what we saw. And then the peaks got muted as the flu progressed to the inner lands. And again, we are seeing similar things 100 years later, and the pandemic has transmission models are incredibly predictable and unpredictable as well, but in terms of the shape. And so if people are seeing this second peak, so you cannot, I do believe that the virus is not going to disappear in February, regardless of which supermodel tells me that. And this is actually a recommendation for for influenza pandemic in 1918. This is in 1920. And you see that the recommendations are also eternal. The first one is wear a mask, live a clean, healthy life. And the last thing I circled, which is very relevant to our conversation here about models and reliability models, do not disregard the advice of a specialist just because you do not understand. I think this is a very fundamental thing that we can talk about science and scientists. And I do think that it is a long haul. We are all tired. Some recommendations are eternal. We have underplayed and underestimated the mental health and the humanitarian aspects that have taken a toll on all of us. We really need to quantify that the morbidity and mortality that happened in India due to delay in care because people are afraid to go see a physician. So what happened to that? And then on the other hand, maybe there is reduction in terms of infectious diseases and gastrointestinal illnesses, as well as accidents. We need to really quantify that. So I actually, I'll be up on a positive note. What I'm seeing in the streets of India, and I'm really glad that I came, is that people are trying. That's not perfect, but they are trying to wear face coverings. The cab drivers, the household helps, the street vendors, they're trying. We are the healthcare, the community health care workers. Yesterday, I saw that they were announcing there will be fines and what you can do in terms of temperature checking. So it's a low resource setting, but I think people are working hard. So 2020 has seen a string quartet between the government, the public, the scientists, the private sector, but the conductor or the maestro has been the virus. And this quartet has not always been in harmony, and it will continue until we have a vaccine. And in the meantime, we'll all have to manage our personal risks. For example, when the pandemic started for the last 8 months, I had been looking at the picture of my parents on my Ann Arbor desk on the left-hand side for 8 months. There came a time when I could not take it anymore, and I came dressed like an astronaut. There was no place for vanity here, taking all the public health precautions possible. My friends laughed about it, and I wrote a Medium article, and this is how our life is going to be. We are going to continue the virus. So that's my closing comment, and I look forward to Gautam's and Giridhar's. Thank you very much.
Thank you, Dr. Mukherjee. Dr. Gautam.
Yeah. So I think what we've learned over the last 9 to 10 months is the fact that data is an issue in India. And it's an issue in multiple ways. Even our death counting under normal circumstances is pretty terrible. It's less than 20% of deaths do you have a medically certified cause of deaths, even though in the cities your registration of death may go up to 100%. India average is probably something like 70 or 80%, but that is an issue. And that's an issue that predated COVID. So now we have to realize much more about the fact that data is important, and the availability of data is also important to people who can analyze it. Let me make another point. ICMR is sitting on the details of every single COVID-19 patient in the country. After now 10 months, we have no idea what is a true IFR that should apply to India across different age groups. They are the people who have this data. If I want to know that, since you have serological data, so you know what the levels of infections across age groups are, you have data about patients, so you know who is dying in what particular age group. It's a matter of statistics to put this information together and produce a map across India for the IFRs. Why do we not have it until now? What is the responsibility of a national agency entrusted with this information? And so this, as an Indian, I feel particularly unhappy about that. I would like to see our national agency do a better job on this as well as other issues. I think it's crucial for us to be able to deal with the consequences of a pandemic, to have clean data, to be able to work on it, and for it to be available to government to make data-driven predictions. That, I think, is something we should concentrate on. I agree completely with Bhramar's point. The larger points about issues of equity come in, issues of public health that is universally accessible come in. The fact that we are not looking at a short time scale, but a longer time scale is also very important. There are many, many tragedies with people who had to move across the country in terms of migrant labor. These are all now have become part of our lives and the way we think about the disease. At least going forward, let's hope that all of the right bricks are in place to make a better tomorrow and a better approach tomorrow.
Thank you, Dr. Menon. Dr. Babu.
Thank you. It was a wonderfully well-organized panel discussion with all the thoughts coming in from different expertise. I just want to leave with this closing note that just to align with the comments already made, the task is not over yet. We still need to avoid the 3 C's: close settings, anything that is crowd-like behavior with the Diwali around, and also, close contacts with any, even family members. And how to wear a mask properly, that's another thing that we need to do ourselves and also ensure others also do it. But at the same time, there are long-term problems that we need to solve together as a community. And we need to extend whatever we are doing. And me, Gautam, Bhramar, we are not doing this as part of our terms of reference, but we are doing for public health system strengthening. I think this is a wonderful opportunity for us to start working together and then ensure that we will try to solve as many problems in the long run. Thank you.
Thank you, Dr. Babu, and thank you for all of you panelists and all the audience also joining us. And one of the reasons that we organize this thing is because most of the time we are among mathematicians or among a statistician or empirical. I think this interdisciplinary approach is coming together. That is one reason why we have you as a leaders in different disciplines coming for this panel discussion. Thank you very much for your precious time and giving us some new informations. Many of the times we don't think in that directions. I would like to convey my gratitude to all of you from the whole committee. And also, I think I see Dr. O.J. Akman here, and I would request Dr. Akman to kind of talk about the beer and say the final words. So, Dr. Akman.
Thank you, Anush. I'd like to welcome you all to beer. My apologies for not being able to make it earlier. I'm really honored that you were able to join us for this great session. and I'm also very happy that you are going to be hopefully a part of our rest of our conference activities. This is the 13th annual BEER conference, fondly known as BEER, Biomathematics, Ecology, Education and Research Conference. We'll start our activities at 7 p.m. Eastern Time today with a keynote presentation, and then BEER conference takes its pride in being a very family, close friends circle conference, and keeping up with that tradition, we'll have a movie to watch, which will be, I guess, like our family movie. And then our activities will continue on Saturday and Sunday. I'm not going to bore you with all those schedule information, but all the information, schedule and all that are available on the website. I hope you can join us during the rest of the conference. And once again, thank you and welcome.
Thank you, Dr. Akman. Thank you once again, all the panelists and all the audience joining us from all over the world. Thank you, Dr. Menon, Dr. Babu, and I think Dr. Mukherjee had some next event in line. Thank you very much.
Thank you so much.
Thank you so much.
Great organization. Great meeting.
Thank you.
Thank you, sir.